ما أدري can you hear me now شباب ولا؟
ممتاز دكتور هشام، واضح.
Excellent. خلاص perfect. خلاص let me see if I can share my screen الحين من التليفون.
نعتذر للحضور شوية على التكنيكال ايشو and we apologize for them. يعني إن شاء الله إن شاء الله نايس ليكتشر بإذن الله.
إن شاء الله بإذن الله. خلاص أنا الحين ما أدري can you see السكرين الحين ولا لا؟
نفس البرزنتيشن اللي أرسلت لك؟
أيوة نفسها إن شاء الله.
طيب go ahead دكتور.
أنا I've shared my screen الحين.
Yeah, it's
can
clear.
you see it?
Yeah.
خلاص perfect.
طبعا دكتور هشام is خطيب, he is consultant in Hamad Hospital Bahrain and he is well known ما شاء الله AO instructor. طبعا دكتور هشام عرفناه من تقريبا 6 سنوات as AO instructor بدبي.
الله يسلمك.
وما شاء الله السي في مليان ما شاء الله من الشيرنج اكتيفيتيز والبارتيسيبيشنز بالكورسز خاصه بالاي او ولا الإيفيدنس ولا شو اسمه الببليكيشن. ما شاء الله دكتور، يعني انا ما وين اقرا وين ابدا بالسي في، بس ما شاء الله عليك اتس ويل نون ما شاء الله فور everybody.
هاي من طيب اصلك، الله يسلمك دكتور، يعطيك العافيه. Thank you very much for the تسلموا. Thank you for the invitation. أنا طبعاً إن أنا كنت already بديت شوية في بعض السلايدز، بس ما أدري السلايدز واضحة ولا لا، فإذا مو واضحة بس خبروني الله يسلمك. فأنا بديت طبعاً الني أرثروبلاستي، بعض الأشياء اللي أنتم تحتاجون you have to think about initially is your assessment, the presentation, the examination, the imaging, and your treatment options. Now, the treatment options can either be non-operative, high tibial osteotomy, uni, or total knee replacement. بالنسبة حق knee arthroplasty, I think you really need to have some kind of idea of some technical considerations, as well as some basic science knowledge. A technical consideration for total knee, أهم شيء طبعا you have to really consider alignment, balancing, whether it's for varus or valgus deformity, flexion extension gaps, patellar tracking. وبالنسبة للbasic science, the key thing is you have to understand the design rationale حقة knee replacement اللي أنت قاعد تستخدمها، لأن not all knee replacements are the same. And some form of tribology understanding, which is the science of metals. يعني different components, different metals are being used, and you have to have an understanding of how these metals work in these systems. وبعدين طبعا outcomes and complications of total knee. عندنا طبعا هاي المريضة يمكن X-ray، هاي واحدة مريضة typical patient who comes to you. You can see that she has advanced arthritis in the X-ray. This is a valgus knee. طبعا the valgus knees, they are unique شوية. Most of the knees you will probably see are mostly varus. في الvarus knee, في الvalgus knee, you will find that you will have some bone loss, mostly in the lateral femoral condyle, as well as on the lateral tibial plateau. And this causes a particular problem. And you have to really look hard into these patients and decide what kind of constraint you're going to be using. It's going to be a straightforward cruciate retaining, or posterior stabilized, or you might be using some stems. Will you be using wedges to address the bone loss? كل هاي الأشياء you have to really take into account before you start. فالclinical presentation طبعا the history is important. You will find that most of these patients obviously come to you with pain. The pain is usually with weight bearing. You have to ask them what the walking distance is. هل عندهم night pain? What kind of analgesia are they using? The previous treatments they've had, and the medical comorbidities, particularly if they're diabetic, if they've had DVT, PE, or are they on warfarin. The clinical presentations, some of the questions really that you have to ask, are the symptoms bad enough to warrant a knee replacement. يعني هل إن الsymptoms اللي عند المريض هذا are they really bad enough to consider a knee replacement ولا لا؟ مش كل مريض يجي لك العيادة إنه you consider him for knee replacement طبعا. The other thing is, are there any other treatments that might help? So have you exhausted everything else before considering a knee replacement? And the next question is, are they actually fit enough for an operation? Is this patient fit حقت a knee replacement? And next thing is there anything else that I need to factor in? Is there anything else I need to look into? The social status, the any other problems the patient might have? And finally, what does the patient want? More importantly, يا أخي بعض المرضى they don't even want an operation. يعني you can't force patients to treat you to have a procedure. We don't treat X-rays, we treat patients. So it's very important to listen to the patient and see what they actually want to do. طب clinical presentation, طبعا you will start by examination. You will look at the general fitness of the patient, the gait of the patient, the alignment of the patient, the range of movement, the extensor mechanism. You look at the stability, the neurovascular status, and the soft tissues. X-rays are very important. You have to get weight-bearing AP views, a lateral view. You can get a Rosenberg skyline. I get long leg views on all my patients, and some patients get MRIs, which is very unlikely. Here's an example of a patient. You can see the X-ray on the left and the X-ray on the right. The X-ray on the left is the same patient without having weight bearing. And the same patient, once he puts weight, you can see that there is a significant loss of joint space. So this is why it's very important to get weight bearing views. The technical considerations, again, you really need to know that you have to achieve شيء اسمه neutral mechanical alignment. The joint line has to be perpendicular to the floor, and you're aiming to restore the joint line and height. You have to have balanced ligaments and an intact extensor mechanism, and obviously avoid any complications. Neutral mechanical axis is essentially a line that is drawn where the line starts from the center of the hip, it goes to the center of the knee, and then to the center of the ankle. The way we achieve a neutral mechanical axis is that we use guides. حقة الفيمر, most surgeons will tend to use intramedullary guides. The tibia tends to be mostly extramedullary, but you do have intramedullary options. You can use navigation, and you can use MRI-specific jigs. The technique for total knee replacement, it starts with preoperative planning. It starts by determining your bone cuts, your coronal balancing, sagittal balancing, and then your patellar tracking. البريوبريتيف planning اتكلمنا عنه قبل, الhistory and examination طبعا. What kind of deformity is it? Is the deformity correctable? هل عندك fixed flexion deformity? وبعدين you'd have to take a consent from the patient. It has to be an informed decision-making process, and you have to set the expectations. It's very important to explain to these patients that this is not something that's going to last forever. It's like like everything else. Even a car doesn't last forever. يعني أنا أقول لهم حتى السيارة ما تقعد للأبد. يعني فإحنا نعطيهم usually 10-year survival. 95% will have a 10-year survival rate. However, we have to be careful because 10 to 20% will be dissatisfied after a total knee replacement, which means that 1 in 10 or 2 out of 10 patients will not be happy after a total knee replacement, which is actually quite high if you think about it. So I think it's very important to set the expectations very clearly from the outset. Preoperative radiographs اتكلمنا عنها, your standing AP views, your lateral views, your skyline views, the standing full length AP hip to ankle if the deformity is present. And then this will determine كذا شغلة. Radiographs will determine your valgus cut angle, which I will explain to you shortly. It will determine your bone defects, the ligament releases that you need to do, and what kind of constraint you'll be putting in your system. فعندنا بعض lines that I like to draw. عندك anatomical axis of the femur, the mechanical axis of the femur, and the mechanical axis of the tibia, and the joint line height. So this will tell me what kind of releases I need to do, what kind of constraint I'll be putting in my system, and the osteophytes that I need to take. The first line that I draw is the Shiasmal anatomical axis of the femur, which is basically a straightforward line that goes into the medullary canal, okay? And this usually determines where the entry point of my jig is, okay? So if you draw the line from the tip of the greater trochanter all the way down the canal, this will tell you when the line exits. This normally indicates where the entry point is into the femur. The second line is the mechanical axis, and this is a line from the center of the distal femur to the center of the femoral head. The distal femur is cut perpendicular to the mechanical axis. So this allows even mechanical loading to the knee implant. So which means 50% medial compartment, 50% lateral compartment. So your cut is actually based off the mechanical axis, not the anatomical axis. فطبعا عندك this is a picture showing the mechanical axis of the femur. The valgus cut angle, which is what you will be putting into your system, is very important. So this is when you will find that most surgeons will tell you they put in a size 5, not size, but they will put in 5 degrees, 6 degrees, 7 degrees. Well, what's it based on? فطبعا يعني if you've done knee replacements or if you've worked with some of your colleagues, you will find that everybody goes for 5. Some people just go for 6. But what you should be doing is that you should be measuring. Okay, every patient is different, and the valgus cut angle is based on the difference between your mechanical axis and your anatomical axis. So it is the angle between the anatomical and mechanical axis, and it's the intramedullary rod and the femur. You select the angle. Normally it's between 5 to 7 degrees, but this is your decision based on the anatomy. So don't just stick to one degree. Not everybody is the same. So your valgus cut angle is the difference between your anatomical and your mechanical axis, and that is how you decide your valgus cut angle, and that will make a huge difference in your outcome. So your valgus cut angle, you have to be obviously wary or be careful or take into account any previous trauma, any obvious changes in the long leg alignment. If the patient is tall, if they have a high hip offset, and the leg length, that is what determines your valgus cut angle. So in the regular patient, regular height, you're looking at a valgus cut angle of 5. If you're looking at patients who are tall, your valgus cut angle is actually less than 5. Short patients, they have, which are shorter than 5 foot, they usually end up with having a higher valgus cut angle. They're less than, it's actually more than 5. The tibia is straightforward because there's the anatomical and the mechanical axis are the same. So if you draw a line that is going through the medullary canal, that is the anatomical axis. And the mechanical axis is actually perpendicular to the anatomical axis, and that's usually 90 degrees. So your tibial cut angle is the angle between your mechanical and your anatomical axis, and it's usually at 90 degrees. So you want to really have a cut which is 90 degrees to the anatomical axis, and that's the tibial cut. Now, sometimes you end up with patients who have this kind of deformity. In this case, this is it looks worse than it is, because if you draw a line from the center of the tibia to the center of the ankle, it's actually straight. So you can do the cuts here without any major problems. The proximal tibial cut is perpendicular to the mechanical axis. So here's an example. This is the anatomical axis, and that's your mechanical axis. So you want to have the difference. The tibial cut angle is the difference between the anatomical and the mechanical axis. So you have to be very careful. So the mechanical axis here for this patient is actually perpendicular to the blue line, not to the red line, because you can see the anatomical axis is well off. Okay, so this does not go into the medullary canal. So that's very important. The next thing we're going to be looking at, so we talked about the mechanical alignment, and we talked about having a joint line which is perpendicular to the forces acting to perpendicular to the floor. The next thing you want is to do the joint line. A joint line is essentially that you have to replace the bone and the cartilage that you have cut off with implants of the same thickness. So if you've taken out 5 millimeters, you have to replace it with 5 millimeters. And this allows you to maintain the joint line and maintain the ligament tension. Usually, this is about 9 millimeters of a distal femoral cut. So the first cut that you will do in all the knee replacement is the distal femoral cut, and that tends to be about 9 millimeters. Now, if you have a fixed flexion deformity, that increases to about, sometimes most surgeons will take an extra 2 millimeters, making it 11 millimeters. So the first thing you do is do your distal femoral cut. The next thing we're going to talk about is ligament balancing, which is very important. You have two planes, which is the coronal plane and the sagittal plane. The coronal plane طبعا is the varus or the valgus releases, depending on the deformity, and the sagittal is the flexion and the extension gaps. I'll start off with the coronal balancing because that's the first thing that you need to address. So you have some releases, whether it's a valgus or a varus release. The goal is to have equal tension in medial and lateral compartments tested in flexion and extension, and you want to have a nice rectangular gap with good femoral component rotation, and the ligament tensions need to be perfect. The femoral component rotation, this is probably one of the most important things in knee replacements, and one of the reasons why most knee replacements will fail. You really have to have a femoral component which is not internally rotated. You really have to externally rotate the femoral component. And this will allow you to have a rectangular flexion and extension gap, and this will be well balanced throughout the range of movement. So if you look at this, this picture here, this is the femoral rotation cut according to the posterior joint line, and you end up with something called the trapezoidal flexion gap. It's not a rectangle. So you can see that there's more loading on the medial side and there's lifting off on the lateral side. And you can see that there's a relative lateral tilt of the patella and a loose lateral compartment and a very tight medial compartment. This will lead to revision. Now, because the reason for this is because you end up having an internally rotated femoral component. If you externally rotate the femoral component, this will perfectly align the cut, and you will end up having a rectangular cut, and this will have equal forces both on the medial and the lateral compartments. So how much external rotation? That's the real question. Slight external rotation of the femoral component. You can see that usually if you're cutting the tibia to 90 degrees, you will probably end up having 3 degrees of external rotation, because normally you end up having, in the normal native knee, it's about 87 degrees. Okay, you don't have the normal human knee does not 90 degrees on the tibia. It's actually 87 degrees, so there's a slight varus. So if you're cutting the tibia at 90 degrees, you then have to factor in the extra 3 degrees, which is why most systems will factor in about 3 degrees of external rotation. So the way we do that, we draw some lines. You have Leo Whiteside's line, which is a line down the middle of the right through the intercondylar eminence. And then another line, which is John Insull's line, which is a line drawn through the epicondyles. So you have a horizontal line and a vertical line. The vertical line is Whiteside's line, and the transverse line is John Insull's line. And the epicondylar axis is very different in most patients. So this gives you an idea of the degree of external rotation. You feel the epicondyles, and then you mark. I usually get a ruler and a marking pen, and I draw this. So this will give you an idea of how much external rotation this patient needs. So the posterior condyles axis, usually 3 degrees, set at 3 degrees in the jig here, and that's the line on the picture that I've shown here. So you have to be aware or be wary of the lateral femoral condylar hypoplasia. Sometimes you have a lot of bone loss, and if you're using the jig to size off the posterior condyles, you may end up internally rotating the femur. So this is the bigger problem. So you have to be a little bit careful that you don't internally rotate the femoral component if you have bone loss. And when you're using the posterior condyles as your reference, that could be the case. The next thing I'm going to talk about now is your ligament tensions. Okay, so the principle here is that you have to release the tight structures, and there's a sequence. So in most knees, whether it's varus or valgus, you have a convex side and a concave side. The convex side is usually the side which is loose and stretched. The concave side is the one that is tight and contracted. So the principle is that if the loose side, you have to fill this gap until it's nice and taut or tight, and the tight side, you have to release to create an equal gap. So I'll start with the varus deformity. So in the varus deformity is probably the commonest deformity you will see, where the medial side is the tight side, okay, and that's the concave side, and the lateral side is the loose side, okay, because the knee is in varus. So you have to do a medial release in the varus deformity. So there's a sequence. I'm not saying that this is the only way of doing it, but this is what's internationally accepted as what you should start off with. So the first thing that you're going to be taking out is your osteophytes. You then need to release the deep MCL, and then your posteromedial corner. And finally, which I've never had to do, is take out the superficial MCL. So this is a picture taking out the osteophytes. In the valgus knee, it's the opposite, right? So you have to release the lateral side, which is the tight side, and fill the medial side. And you have to be a little bit careful of the perineal nerve. So the valgus knee, you will find that the concave side is the lateral side and the convex side is the medial side. Again, there's a sequence. So we start off with the osteophytes. You then take out the capsule. You can release the popliteus, and then the ITB band, and then very lastly, the lateral collateral ligament. You have to have a clear understanding with valgus knees that, you know, a lot of patients, a lot of surgeons, I've seen them just take the popliteus out and then they then take the ITB. I think you have to have a clear understanding of what these structures are doing. So the popliteus will do nothing for extension. It is a purely rotational force that will change, and it might help in some flexion. So if you want to get more flexion, you can release the popliteus. But if you have a problem with extension, it will not change anything. So there's no point releasing the popliteus. If you want to get extension, it's the ITB band. And again, the same thing, if you want to get flexion, there's no point releasing the ITB because it's got nothing to do with flexion. Most valgus knees, they have no problem in bending. They can flex easily. It's usually the extension. So I think popliteus release is not really going to be of any help to you. But, you know, it's something to consider. So these are the structures you can see here, the popliteus, the lateral capsule, and the lateral collateral ligament. So I think it's very important. So the ITB band is what I mentioned. If the knee is tight in extension, that's what you release. If the knee is tight in flexion, then it's the popliteus. The lateral collateral ligament release. So the popliteus tendon inserts into the lateral epicondyle just in front of the lateral collateral ligament. This is where you do your popliteus release, and then this is where you do your ITB release. Flexion deformity. So you have to fill up the flexion gap until the ligament complex is taut. This can be done by posterior releases to achieve full extension. So most of the time, by just doing a posterior release, you should be able to get the knee out to full extension. If not, you may need to consider some bony cuts. So we've now talked about coronal releases. Now, exact same thing happens in the sagittal plane. You have a concave side and a convex side. The concave side is the posterior side, which is the tight side, and that's what you have to release. So again, what do you release? You have to release the osteophytes, the posterior capsule, and then finally, you may need to release the hamstrings, particularly the gastrocnemius muscle. The posterior releases are performed with the knee flexed, and that's obviously to avoid any injury to the popliteal artery. I would suggest that you never do any releases with the knee in extension because you may injure the vessels in the back. So the sagittal plane balancing, you have to really balance the gaps, matching the flexion gap to the extension gap, the bone cuts, your soft tissue structures, the full range of movement, and the knee has to be stable in all positions. I sometimes use a laminar spreader, like in this case. So this is the flexion gap, and that's controlled by your bony cuts. You can use posterior femoral cuts, tibial cuts, and you can release the soft tissues, particularly the PCL. So this is with the knee inflection. The same thing happens again with extension. This is controlled by your bony cuts and your soft tissue. So the bony cuts that control the extension gap are your distal femoral cut and your tibial cut. And your soft tissues are going to be mostly the posterior capsule. So again, and for the flexion gap, what controls it is the posterior femoral cut and your tibial cut. And the soft tissue is the PCL. For your extension gap, it's your distal femoral cut and your tibial cut, and it's the posterior capsule. So balancing the gap. So I'm going to simplify it for you, okay? So if you have a symmetrical problem, okay, which means that the knee is tight in flexion and in extension, then that's very easy. Then the easiest thing to address is take more tibia out, right? Because the tibia will control both flexion and extension. If it is an asymmetrical problem, which means it's either tight in flexion or in extension, then you have to address the femur. So if it's a symmetrical problem, then usually just taking more tibia out will solve the problem. If it's an asymmetrical problem, then you have to look into the femur. So let's look at the various options. So if it's a symmetrical problem, it's tight in flexion and extension, then it's easy. You just take more tibia and that will address both the problems for you. If it's loose in flexion and extension, that means you have to add more poly. All right, so basically you have to put a thicker insert. So that's the symmetrical problem, that's the easiest thing. The asymmetrical problems are a little bit more tricky. So let's say that you have a knee which is tight in extension, but normal in flexion. So remember what I told you, if it's asymmetrical, then you have to look at the femur now. There's no point looking at the tibia because the tibia will address both. This is purely a problem in extension. So what you have to do is take out more distal femur, right? So by taking out more distal femur, this will allow you to achieve full extension. Here's another problem. Now you have a knee which is tight in flexion and normal in extension. So it's tight in flexion. What does that mean? That means you have to take out more posterior femur. Okay, so because it's tight in flexion, that means you can see the red line here. So release the PCL, and then maybe you're going to have to release your or take out more femur from the posterior condyle, which means you're probably going to have to change your femoral component. The easiest thing that you do when you trial your component is you look for something called a polo test, or the pull out and lift off of the tibial insert. You can see that this plastic is lifting off, which usually means that the knee is tight in flexion. So the flexion gap is too tight, and which means you either have to do a posterior release, or if the PCL is not sacrificed, you may have to do a extensive PCL release. The way to release the PCL, this is from Ranawat's technique, which is pie crusting, where you basically get a diathermy or a blade and you start making little cuts into the structure, and then you release it off the femur. So there's a sequential way of taking it out, the PCL. And then you check your posterior slope. The normal slope of the tibia is about 6 to 10 degrees. Some implants have the slope built into the implant. Some need to be cut for the slope. So you have to really know what system. So you have to understand the system that you're putting in. So now we're going to continue with the asymmetrical problem. So now you have a knee which is normal in extension, but loose in flexion. That means you have a big posterior, your posterior femoral condyle. You've taken too much posterior femoral condyle, which means you have to add a posterior femoral augment. Okay, so that's a problem. So most systems may not allow you to have that. So that's something that you need to take into account. So so that could be something that most systems won't have. You can add more tibia and cut more distal femur but that raises the joint line. So one of the ways to get around this problem is that you can take more tibia and cut more distal femur, but you're going to have to put a bigger poly in that case, and that's going to raise your joint line. So you can see that the AP gap here is loose, okay, and you fill the gap with a metal augment or cement to try to correct that. So you can then translate the femur inferiorly to close that gap, and you fill the gap again either with a metal augment or cement. The other thing, finally, the last asymmetrical problem is the knee is loose in extension and it's normal in flexion. So that means you're going to have to distalize the femur, right? Because you can see that there's a big gap. So again, the way to do that is to add tibia and then address the tight flexion, downsizing the femur. So this is pretty tricky again, because you really have to distalize. You want to get more femur distally, right? So because you've taken too much bone off the distal femur, which means that you have a knee which is loose in extension. So one of the ways is that you put a bigger poly, okay? So you add a bigger, you add the tibia, and then you will end up having a knee which is tight in flexion, which means you may have to then put a smaller sized femoral component, which again may make things a little bit more complex because you may have to notch if you're not very careful. So this is probably one of the most difficult problems that you may have to face. But these are things that you have to understand. These are things that can happen, but are avoidable if you plan carefully preoperatively. The next thing I'm going to talk about is the extensor mechanism, and this is where we're going to talk about patellar tracking and the Q angle. And I think it's very important that you protect your patellar tendon and avoid overstuffing the patellofemoral joint. So what is the Q angle? The Q angle is basically the angle between a line bisecting or a line which is effectively defining the pull of the quadriceps, and that's a line from the anterior superior iliac spine to the center of the patella, and a line bisecting the patellar tendon. So the blue line, if you look here, is just a line that's going through the patellar tendon. The red line is a line that goes all the way to the anterior superior iliac spine. The distance between them is the Q angle. So if you have a wide Q angle, you're going to have a subluxed patella, and the prosthetic replacements tend to be less constrained than the native patella, which means that there's there's more movement in the artificial knees. They're more likely to sublux with an increased Q angle force. So you really want to optimize your Q angle, okay? So reduce the excess valgus alignment, correct it to neutral in this case, optimize the Q angle, avoid internal rotation. We've talked about this. Internal rotation is the worst thing that you can do. If you internally rotate your femoral component, you will then have patellar maltracking and patellar liftoff. And also be aware of we talked about this in the valgus knees, because you may have a hypoplastic femoral condyle, and that may lead you to internally rotating the components. So here's an example of internal rotation of the tibial component. And you can see that the tibial implant should really line up over the medial third of the tibial tubercle. So you want to have your tibial component over more or less over the medial third of the tibial tubercle. I tend to use the bony landmarks to put my tibial component. So the normal Q angle, the tibial implant should center over the medial half of the tibial tubercle. We talked about this. An increased Q angle will cause increased subluxation. The tibial rotation, there are multiple methods to assess rotation. There's lots of ways of checking where you put your tibia. Mostly it's the medial third, central third of the tibial tubercle. So if you look at your tibial tubercle, the tibial tray should sit somewhere in the medial third. Some use the axis of the PCL insertion to the center of the tibial tubercle. Some use the back. Some use the back of the plateau, laterally rotate to the front anteromedially, and some use the axis of the second ray of the foot. I don't think that's very helpful. You want to then, if you're going to be doing a patellar resurfacing, you want to medialize the patellar button and lateralize the patellar femoral component. So you want to put your femoral component as lateral as possible and your patellar button as medial as possible. Medializing the patellar button and lateralizing the femoral component will optimize the Q angle. Avoid overstuffing, so basically, which means you don't want to be putting too much patella into the, or too much plastic into the patellofemoral joint. The thickness of the residual patella plus the poly of the button. Make sure that you know how much patella you're taking out, and the trochlear bone resected anterior implant thickness. The large dome tightens the lateral retinaculum and leads to a patellar tilt. I think the patellar tendon injury is a very big problem. You really have to be careful and pay close attention to the patellar tendon. Be careful of exposure and eversion and of your cuts. The extensor mechanism is very crucial to prevent patellar baha, which basically means if you've got the patellar which is very low. This could be from previous osteotomy or previous surgery and often seen in revisions. Patients who have had a previous patellectomy as well may need a posterior stabilized implant. I don't think it's fair to just put a cruciate retaining implant in these patients. They need more constraint. So this is an example of a patellar baha. You're going to have to modify. You can see that the patellar is very low. You're going to have to modify your patellar resurfacing. You may need to put a smaller button and place the button quite superiorly. You may have to shave off a little bit of the tibial poly, lower the joint line, raise the tibial tubercle, and sometimes even do a patellectomy. Finally, I'm going to talk about complications. I don't really resurface the patella routinely, but there is an argument if you don't, in some patients, you may end up with pain. If it's resurfaced, it may lead to loosening or wear. There may be a patellar fracture. There may be an extensor mechanism rupture. Other complications include infection, DVT, pulmonary embolism, medical complications, nerve vessel injury, particularly the common peroneal nerve in valgus knees. You may have fractures, ligament injuries. You may have some wear and loosening, and pain, stiffness, and finally chronic regional pain syndrome. Thank you very much. I hope this wasn't too much for you this evening. I hope I've covered everything that you need to know. I think this is pretty much all that you need to know from an exam perspective. I don't think you need to know more than this for most orthopedic exit exams, whether it's Saudi board or those sitting the FRCS orth. And I hope this was useful. Thank you very much.
Thank you, Dr. Hisham. Allah yatiq al-afiyah. Please, if any question for Dr. Hisham, you can just open your mic and ask. Thank you, Dr. Hisham, for a nice presentation. And also in our platform, Learning Curve, the presentation will be recorded already and will be in the YouTube, and you will get it also in our Twitter account, Learning Curve. So if any question for Dr. Hisham? So I think there is no question. Thank you, Dr. Hisham, for your presentation. Inshallah, لنا لقاءات, another meeting. And
Inshallah, يعطيكم العافية.
And احنا نعتذر شوي عن الخلل والتكنيكال issue for this time. Inshallah, we'll prevent next time. Thank you everybody for your time, and يعطيك العافية Dr. Hisham.
يعطيكم العافية. All the best, and I wish you all the best, guys. I'll see you soon, inshallah.
Thank you.
Assalamu alaikum. مع السلامة.